He is going to talk to us about some research on opioid prescribing. Obviously, opioids prescriptions have become kind of a very, very common discussion topic, both within the medical community and within policyholders. And I think it's important for us to keep our eyes on updated research and learn more about this. And I thank you very much for taking the time to give us this talk. Feel free to take it away.
Okay. All right. Well, thank you for the opportunity. I'm going to start by sharing my screen, and you can let me know if this all works out. Okay. How does that look? Do I need to swap anything, or are you seeing?
Looks good.
That looks good.
Looks good. Okay. Well, thanks again for the opportunity to talk to you today about opioid prescribing in primary care settings. I know it's a little bit of a different audience, but hopefully we'll have some kind of crossover and common themes to discuss. I wanted to first acknowledge many co-authors and collaborators who've been a part of the work that I'm going to talk about today. And I'm, just for a little bit of background, I'm an associate professor in the Department of Family Medicine and Community Health here at UW-Madison. I'm the principal investigator of the Implementation Science and Engineering Lab. So we throw the word engineering in there because my background is as a systems engineer. So I am not a physician, but work mostly with primary care and family medicine physicians. And we're focused on kind of short and long-term opioid prescribing for chronic pain in primary care settings. All right. I have no relevant financial relationships with ineligible companies to disclose, and I do not intend to reference unlabeled, unapproved uses of drugs or devices in the presentation. I do want to acknowledge that I've been funded by grants from the National Institutes of Drug Abuse. This one is the one I'll mostly be talking about today, but I have been funded continuously by NIH since 2015. I do work with a digital health company and provide consulting on digital health implementation for the NITEX Foundation, which is a nonprofit. So I'll give you the reason why I got involved with this topic. This chart shows the change in the total volume of opioids prescribed in the U.S. healthcare system, starting from around 1990 through 2017. So you can see that there was a steady increase in opioid prescribing throughout the 90s, all the way up until about 2011. So a sustained 20-year buildup of opioid prescribing for chronic pain. And things started to move in the other direction in around 2011, 2012. And I didn't put this all the way up to the present, but there has been sort of a reversal in course for opioid prescribing has subsided. But obviously got to a really high peak about, I guess, 14 years ago now. And the problem with this, to a lot of you, is that there's research that came out in 2010, which I think is part of the reason why things started to change around 2011, showing that the risk of overdose is directly correlated with the morphine equivalent daily dose. So this just shows that patients who are prescribed less than, or let me say it this way, patients prescribed more than 100 morphine equivalent per day are more than 11 times more likely to overdose than patients who are prescribed less than 20 morphine equivalent per day. So this got a lot of attention and sort of signaled the need to be more judicious in prescribing opioids. So I wanted to kind of trace the history of how this sustained 20-year increase in opioid prescribing came about. So this study here by Porter and Jick, it was published in the New England Journal of Medicine in 1980, cited more than 1,000 times at the time when I pulled this. And the title says it all. It says addiction is rare in patients treated with narcotics. And this is an article that was cited frequently by pharmaceutical companies to sort of downplay the potential risks of opioids. I'm going to now show you what that article consisted of. Maybe some of you have seen this, others maybe not. I'll give you a minute to take it in. This is not the abstract of the article. This is the entire substance of the article. It was simply a letter to the editor of the New England Journal of Medicine with a couple of physicians who's done sort of a database study within their own health system. No real rigor or control in this, just showing, we looked at a lot of people and we didn't see that they became addicted to opioids, but there were obviously a lot of shortcomings with this type of research, being cited to inform policy and clinical decision making. So that's kind of the history of how this came about, for better or for worse. So I got involved with this. The first grant that I wrote was in 2012, and have been continuously working on strategies to de-implement opioid prescribing in primary care ever since. So this article was published in JAMA Network Open in 2024, and is kind of the main topic that I'm going to be talking about today. So really, this is something that might be familiar to a lot of you as well. CDC in 2016 published a guideline for prescribing opioids for chronic pain. And this laid out a series of recommendations to try to mitigate, in response to the growing concern over the epidemic of misuse and overdose. Some guidelines primarily geared towards primary care clinicians to follow, to hopefully mitigate the risk of opioid misuse and addiction. I mentioned earlier that my background is in systems engineering, and the grant that we wrote that I'll be reporting on today was in response to NIH's program announcement on dissemination, implementation, research, and health. And they explicitly talked to the nature of systems being multi-level, multi-component, words optimally delivered and implemented in various settings. I have to consider the multi-level context and environment in which the research is conducted, and look at relationships between levels within the system, patients, providers, and systems. So what is this? This is a book by Herbert Simon, who's been a real influence to me, and it just kind of backs up the need for multi-level systems. Complexity frequently takes the form of hierarchy, and this is a central structural scheme that sort of manifests in the architecture of complexity, so that a system is composed of interrelated subsystems, each of the latter being in turn hierarchic in structure until we reach some lowest level of elementary subsystem. So this is how we kind of conceptualize and operationalize that multi-level architecture of complex systems. So patients receiving opioid prescriptions within primary care clinics. So we We layered a series of different implementation strategies to try to implement the guidelines for opioid prescribing that CDC had issued in 2016. The first strategy is educational meetings, which is a health system level strategy. We worked with expert physicians to kind of go over the guidelines, and provide guidance. We started with this because it's, kind of general, minimally intensive. We provide performance feedback reports at the system level so that individual clinics and clinicians would know how they're doing around their opioid prescribing metrics. The next level of implementation strategy that we provided is called practice facilitation, a clinic level strategy that targets clinic processes and workflows. Compared to educational meetings, it's a little bit more tailored and labor intensive, but it allows clinics to kind of customize their implementation approaches to their unique contexts. And then the most intensive implementation strategy that we provided, we called physician peer consulting, which is a prescriber level strategy, where we would have experienced physicians with knowledge of addiction, chronic pain, and opioid management, talking to primary care clinicians about their most challenging cases and kind of what to do in unique circumstances. So it's the most tailored and highly resource intensive of the implementation strategies, but those were the multiple levels of the system we were trying to intervene upon. So in this study, we used what's called a sequential multiple assignment randomized trial design. And so it just kind of lays out what I talked about before. This study took place over a period of 21 months. We began with all of the clinics who we recruited, starting out with educational meetings and audit and feedback reports. At 3 months, there was a first stage randomization where half the clinics received practice facilitation level strategy. We carried that on for 6 months. And then at 9 months, there was a second stage randomization where half the clinics again were randomized to receive prescriber peer consulting. So this resulted in 4 different combinations of strategies where some, a quarter of the clinics only got the system level strategy, a quarter got the system level strategy plus the clinic level support, a quarter got system level strategy plus provider level support, and a fourth of the strategies received all 3 of the implementation strategies, each strategy at each level. And this is, we call this an implementation trial. It's a type 3 implementation effectiveness sequential multiple assignment randomized trial. We recruited 32 primary care clinics representing 268 providers and almost 9,000 patients from 2 Midwest healthcare systems. So UW Health, family medicine and internal medicine clinics were one of the systems. And then we also worked with Bellin Health in the Green Bay area. So 2 health systems, 32 clinics. Our primary outcome was the change in morphine milligram equivalent at the patient level, and clinics receiving the least intensive strategy, which was educational meetings with performance feedback, versus the most intensive strategy where they received all of the strategies at the system, clinic, and prescriber level. The secondary outcomes included adherence to guideline metrics and mitigating opioid risk. So these are all recommendations from the 2016 CDC guidelines. So it's things like not co-prescribing opioids with benzodiazepines, providing annual urine drug screens for patients on long-term opioid therapy, doing
treatment agreements when initiating opioid prescribing and reviewing those over time to kind of have informed consent about the risks and benefits of opioid treatment. We also looked at proportion of patients getting more than 90 morphine equivalent per day based on the sort of known risk factors around those higher doses. And then patient screening with the PHQ-2, depression screen, and patient screening with the PEG-3. PEG-3 is a 3-question screener that asks patients about their levels of pain, enjoyment, and general function. So it's meant to kind of balance opioid dose with some of these functional measures of quality of life. So our analysis was multi-level. We had prescriber and clinic level, piecewise linear model with a knot at intervention month 9. Right before the second randomization was used to model trajectories and outcomes from months 4 to 21. And importantly, we included a patient subgroup analysis to examine differing guidance for acute versus chronic patients. And the reason we did this is that CDC provided a little bit later on in recognition to some of the needs of these patients, has different guidance for patients who were acute or subacute, and that's defined as getting less than 3 months of consecutive months of opioid prescriptions versus patients on longer-term opioid therapy, which is defined as more than 3 months of consecutive opioid prescriptions. So again, this is the consort flow diagram showing the breakdown of the clinics. So with 32 clinics, we ended up with roughly 8 clinics per intervention arm. We had only 1 clinic that dropped out after randomization. So 32 clinics randomized and 31 analyzed. And it also shows the breakdown roughly equivalent between sort of short-term and long-term opioid patients.
Anyway, so this table shows the baseline outcomes of at baseline, the race and ethnicity and sex of the patients. Again, this is Wisconsin clinics, so roughly a little bit more female than male, largely white population. I think importantly, the average MME prescribed in the last quarter was around 40 across the different intervention groups. So you had around 10% who were getting above 90 morphine equivalents. That's kind of the risk factor that the guidelines refer to. And then I won't go through all the metrics, but we'll kind of look at changes in outcomes for the secondaries. So moving on now to the changes in outcomes. So we're going to focus on, there's a blue arrow kind of at the top of the screen. There's a lot to take in with this slide. But the primary contrast, again, that we're looking at, and the primary outcome is mean morphine equivalent dose. So when we compare the change in morphine equivalent dose over 18 months between the most intensive group and the least intensive group, there was a statistically significant decrease of 2.4 morphine equivalent. Again, we're talking about like 40 as the baseline between the most intensive and the least intensive group. We also saw, and we'll kind of get into some of this later, but interestingly, we saw changes in urine drug screening and treatment agreements, but in the opposite direction that you'd hypothesize. So that, when we went in, we figured that
urine screening and treatment agreements were part of the guidelines. So the most intensive group would have the largest increases in these outcomes. However, what we actually saw is that the group getting the most intensive strategies did far less urine screening and use of treatment agreements. So that was kind of a surprising finding that we'll discuss in a little bit more detail. And then again, sorry, this is just a continuation of the previous slide. We also saw that the most intensive group did significantly more PEG-3 screening. So this is screening for pain, function, and quality of life. So that was in the direction that we hypothesized. So in summary, the most intensive group prescribed fewer opioids, did more pain screening, less urine drug testing, and less treatment agreements. When we look at the patient group analysis, again, we're comparing the most intensive to the least intensive group. When we look at on the left the sort of acute pain subgroup, so those with shorter than 3-month prescriptions, sort of bordering, we didn't power the trial this way, but you see that there's a more significant reduction in MME for the short-term patients, and really not much of a decrease in MME for longer-term patients. And I think that's the one thing that's probably most important to glean from this slide. Likewise, there was in urine drug testing and treatment agreements, really most of the reduction in those was due to less urine drug testing and fewer treatment agreements done in the group who is on long-term opioid therapy for chronic pain. So just to summarize, compared to the system-level strategy, the multi-level strategy reduced opioid dose by 2.4 units, about a 6% decrease, statistically significant. So modest, you can argue over the clinical significance of that. We did see that the reductions in dose were driven by lower doses in acute and subacute patients. And compared to the system-level strategy alone, the most intensive multi-level strategy increased pain-related screenings by 5.4% and decreased urine drug screening and use of treatment agreements. So, we spent a lot of time trying to kind of contextualize and put these findings into context. So this article that I pulled is from 2019. We started this project in 2018, and 2019 was as we're getting started with our implementation. We worked with some of the guideline authors in earlier stages of this project, and there was some recognition that the guidelines are being misapplied, particularly in cases of patients with high opioid doses. Taking, it's kind of unfortunate when patients end up on high opioid doses, but how to manage and reduce opioid doses for patients who are in that position can be really fraught and challenging. So we had to, our physicians kind of had to incorporate that guidance mid-project. And so the first guidelines came out in 2016. In 2022, February 10th, this is almost exactly at the end of our implementation period, CDC toned down their guidelines on opioid prescribing. And a lot of it was in response to the potential harms associated with involuntary tapering of patients at high opioid doses, especially for those who've been taking opioids for a long time. So again, here's the latest guidelines that came out in 2022. Roger Chow was the lead author of the 2016 guidelines and the senior author of the 2022 guidelines. So continuity there and recognition that these guidelines are subtle and complex and have to take some nuance into consideration when implementing them. So here's some of the key changes in the guidelines between 2016 and 2022 that really affected some of the outcomes that we saw. And as we were seeing our results come in, this kind of helped explain some of what happened. So dosing thresholds were really a focus of the 2016 guidelines. 2022, there was no strict dosage limit, and there was advocated for more flexibility and individualized care. Treatment agreements were also kind of featured in the 2016 guidelines, and were made mandatory by some healthcare systems, including the clinic or the health systems that we worked with. But 2022 also, based on sort of a lack of evidence for the effectiveness of treatment agreements, advocated that these treatment agreements should be less rigid and focus on shared decision making and not really geared around enforcement and punitive actions taken against patients. Urine drug testing as well was sort of a main feature of the 2016 guidelines. 2022, there still are recommended, but really the guidance was toned down significantly again, that it shouldn't be mandatory for everybody, and not as rigidly applied. Stigma can be a big issue with urine drug testing. And the 22 guidelines shift the focus to patient education rather than punishment. Urine drug testing could be and has been used as a way to kind of discharge patients from care, and a lot of times those patients end up in bad situations if they're suddenly not receiving opioid prescriptions from their physician and have to go to other sources. So implementation research is complex, and as we interpret the results of this multi-level study, one thing I think that's important to recognize is that this is kind of a law of nature, that the human brain can only process 60 bits per second of information, and this is true across the board for patients, primary care physicians as well. So when you have guidelines with, I think the CDC guidelines have 12 recommendations. When there's limited time and a lot of things to prioritize, our most intensive physician-led strategy focused in on screening for pain, enjoyment, and quality of life, de-emphasized treatment agreements and urine drug screening, and did still recommend that for patients who are new to opioids, starting low and going slow. So when we kind of take another look at what happened in this study, it really did reflect the evolution in the clinical guidelines. So that was something that kind of took a little bit of time for us to unpack. I think I wanted to just say a few more things about the nature of doing implementation research in complex systems. And we saw this play out. This is the concept of wicked problems. Diverse values are held by different groups of individuals. That which satisfies one group may be abhorrent to another, and what comprises problem solution for one is problem generation for another. Under such circumstances, and in the absence of an overriding social theory or an overriding social ethic, there's no gainsaying which group is right and which should have its ends served. So I think this is one of those cases where, health systems and policymakers had good intentions, but, potentially had some negative consequences by involuntarily reducing opioid doses for people on long-term therapy, and sort of rigidly applying enforcement activities that don't have a lot of clinical benefit. Just to mention a couple of limitations. Again, these were pretty well-resourced health systems here in Wisconsin. We are augmenting our quantitative analysis with economic and qualitative analyses. And I think one thing we're left with, when we do a study like this, we have to pick one outcome. MME might not be the best thing to focus on to the exclusion of all others. And we really, we now know that opioids were not the answer for chronic pain, but what is? And that's where our future research is going. Our approach has been kind of top down in the sense that we provide system level, clinic level, and prescriber level support in sequence. Research from behavioral economics stresses the importance of loss aversion from a patient perspective. So, we saw this, I think pretty early on, that if we are taking, the idea is to reduce opioid dose, there's no reason to think that chronic pain is going to change, one way or another. In fact, all the stats are showing that chronic pain is becoming more prevalent. So if we're taking away the frontline therapy for chronic pain, especially for patients already taking opioids, we have to find something to put in its place. Otherwise, we're going to sort of cause mental anguish just by loss aversion alone. So there's a lot of promising interventions from there's integrative health, also new pharmacological drugs that could be promising. We're specifically looking at research, to feature group medical visits, digital health interventions, mind-body modalities like meditation and acupuncture. And, our hope is, like, going forward, now that we're all kind of convinced that opioid therapy for chronic pain isn't a great idea, can we close the loop by providing more safe and effective interventions to patients to treat their chronic pain? And that is all I have. So thank you for your time. I have a link to our lab website where you can, learn more about this study and other research that we're doing in our lab. And there is a link to the paper that I reported on today. And I think I'll stop sharing at this point. And looks like we probably have about 9 minutes for discussion and Q&A. So I'm open to any questions you might have. And I'm curious, how, as from a neurosurgery perspective, how primary care interfaces and the relevance of this and how you're using opioids. I know it's obviously a completely different clinical context. So I don't know to what extent these, what we're seeing in primary care translates between settings, but be interested to hear any questions or thoughts on that topic.
Well, I do have a question. Thanks very much for this. We appreciate it. A lot of what you talk about talks in the context of national guidelines. The present state of the CDC is, let's say, difficult regarding its presence and its authority, which creates quite a void. Do you think there'll be anything that's going to fill that, or how will we react without trusted guidelines coming from an organization like that?
Yeah, I mean it's a great question, and certainly, we published this paper in October of 2024, so things have changed a lot since November of 2024. I mean, guidelines do come from different sources. CDC is not the be all end all. I don't know. there are medical associations and other organizations that issue clinical guidelines, and maybe it's just a matter of I think the COVID effect and CDC kind of coming under the crosshairs for all of the controversy around COVID has spilled over into other areas. I don't know if one thing I'm not sure about if there are neurosurgery guidelines for opioid prescribing, or other, I'm sure there's other kind of professional guidelines that could be referred to. I think that's at least one possibility. I teach a course on translational science, and encourage students to seek out sources of the most where do you find the best evidence base for clinical recommendations, and CDC is not always the answer. So I'm not sure if there's a counterpart in your world of neurosurgery that you could go to, but
Other questions? I think that we appreciate very much. We do have our individual societies. We do have our individual guidelines for practice. I would have to say that we've not emphasized this as much as we should, especially with our spotting programs. Although it is an emphasis with the modalities of care moving towards stimulation and other principles. But thank you very much for the presentation, and appreciate you being here today. Thank you.
all right. Well, thank you for the invitation.